The next thing we're going to have is a panel. I'm going to ask Dr. Oluoch-Olunya, Dr. Okoth, Khalif, and let's see, Dr. Copeland, Dr. Will Copeland. Could you all please come up, please? So this panel discussion is going to talk about, we're going to discuss neurosurgery in Kenya, present and future. This is a chance for you as the audience also to participate and ask questions. I'm going to start off by asking a few questions, and then please feel free to raise your hand if you have a question, and we'll pass a mic around so that you can participate. So the first thing I'm going to do is I'm going to ask them to introduce themselves. Right, and each one of the panel themselves and tell you a little bit about what they do. Use the mic. Just pick that mic up, please.
As you might have seen, my name is David Oluoch-Olunya. I am a neurological surgeon. I had the privilege of being trained at the University of Nairobi, and I did my one year. One of the things that brought me back was impact factor. The fact that there could be one amongst many, but I'd also had the privilege of speaking one day when I was referred a patient from Southampton. It was him who was there. He's more senior to me, but we started talking, and the fact that we were both coming back, the issue of trying to get neurological surgical training in Kenya. I'm currently based in Nairobi at the Nairobi Hospital. I also consult at the Khan University Hospital. I am a resident more often now in Kisumu. Surgeon. I've got an interest in skull base, especially in the pituitary region, also endoscopy. I have the dubious honor of doing one of the first endoscopic systems.
I'm the teaching and referral hospital.
Speak up a little bit so we can hear you all the way in the back. Let me make sure this mic is on. I briefly describe to us one of the things we sometimes have a hard time. I think you're probably the best resource to describe to the audience. What is neurosurgery training in Kenya? How long do you train? What's kind of involved in the curriculum? What facilities do you train at typically? So can you just give us a quick overview of what neurosurgical training in Kenya is like? And I see Dr. Oluoch mentioned there's two. Okay. Programs based neurosurgical training, which is MMed. Neurosurgical resident, stay there for 6 years, do an exam, and then exit as a neurosurgeon. That's one of the ways, and that's not the one I'm not in. So I'm in a program called COSEXA. It's a program that is also training neurosurgeons in this region, but not only in Kenya. It's training in Tanzania, Uganda, and in 19 other African countries.
So it's a bigger program. So what it entails is we have 2 years of general surgery training. It's called MCS. You have to do an MCS exam. You become a member of the College of Surgeons, and then you can apply for neurosurgery fellowship, which is 4 years. So in this training, the main principle is that you learn from different people and from different centers. So let's trauma patients, maybe in Eldoret, Mombasa, Kisumu, or Kenyatta. So that's the main principle. If you need to do something about endovascular, you need to go to a place where they do coiling, clipping, you know. So that's the main principle. It's learning from the best in every institution. So there is no way you can have as an institution which can provide all this neurosurgical specialty in one place. It's difficult to get that in this region. Therefore, the main principle is to learn from different people and different centers. So that's the main principle, and we're very grateful to the people who started this program, Mr. Oluoch-Olunya, Mr. Qureshi, who were the pioneers of that, and the people who've already finished the program, Dr. Ben Okanga, who was my former boss at Coast General Hospital, and many others who are already neurosurgeons in the region and who are from the COSEX. Have one surgical exit exam for the whole country, and he was thinking at that time that maybe that the COSEXA exam will be a standard exam for the region. So that's that. We're very grateful. We've got a lot of resources in the online, on the website of COSEXA, and what we do is that we've got a lot of contacts with other institutions. Mr. Qureshi just the other day got us a rotation in Spain, 3 months rotation in a brain lab, which is one of the best in Spain, that is run by Professor Pablo Gonzalez and Jose Pique. We have a rotation in Italy.
Because I noticed that you're still addressing some of the neurosurgeons as Mr.
I think I'll answer that. It's actually it's a, and in the United Kingdom, surgeons were not doctors. They were. The Queen gave a royal charter to allow them to do medicine. After that, as a distinction, when you become a surgeon, you drop the doctor bit and you become a Mr. or a Ms. So that's a past. In Australasia, they use that as a Mr. or Ms. But that's the reason. It's just that. Once you become a surgeon, you drop the doctor bit and become a surgeon. Because I'm a fellow, I use that as a title. There was this myth that Mr. is more than a doctor. If you become a doctor, you become Mr. No, it's just that you are part of the guild of surgeons. That's it. So those who use Mr. tend to be ones who have been trained in the British system or the UK system. That's all.
So you would not be offended if I called you doctor?
No.
Thank you.
Thank you. Any other questions? Any other questions from the audience? Okay.
I'll take one, if you don't mind.
Yes.
Thank you. Thanks for coming.
Introduce yourself.
My name is Chris Karras. I'm Dr. Orr's partner in the United States. And I was just wondering, what's your greatest challenge to educating neurosurgical residents in Kenya? What makes it most difficult for you to educate the residents in Kenya? Is it volume? Is it resources? Is it the need to travel?
You do. I don't know why you gave this to me. I'm not yet training neurosurgeons. I'll pass on to Dr. Oluoch-Olunya.
Notice said Dr. Oluoch-Olunya. Yeah. The difficulties in getting them trained, it's competitive to get in one. On the COSEXA program, we keep it small because the apprenticeship is very close-knit. We tend to have 3 per year, and we watch them like hawks. So, and the apprenticeship is such that you cannot let someone do any much more until you are sure they can. you can imagine the same way you train a pilot. When you're on the left, you are the main, and you got the first officer. And the first officer should be able to handle the plane until he cannot, and then the man on the left does so. And that's what we do with them. I benefited from that training, and both Mr. Qureshi and I did the same. And we thought it was invaluable. And the thing was that you do not stick with one person, and you do not stick in one center. So to come back to your question, the challenges are, case mix is plenty. Cases are too many. In terms of getting the equipment to be able to cope with the load, sometimes can be a challenge. The distances to travel in terms of where to get the places. Now, Khalif is here in Kisumu. Last week he was in Zanzibar. Most of the time he was in Nairobi. And there are two of them who are rotating. Since he's a senior one, as a senior resident, it's on your lap. So he's getting ready to sit on the left. So therefore he has to take the load. And sometimes I look at him and he can almost fall over. And it happened to me when you've had a whole weekend on call. And that's when your boss tells you, we are now softer. We are not as harsh as we used to be. They used to be to us. So I sometimes, can you imagine, I buy him a cup of tea or let him sit and rest. And if I see he's shaking too much, we have taught him how to make sure his hands are held so he doesn't make a problem. So case mix is enough. The case load is a lot. The other thing that we have a challenge with is like now in Kisumu, when you're trying to build up the facilities, in order that you cope, there are certain things that are disposable, you don't have. There are certain things that, pieces of equipment, which it's nice to, you should have, but you cannot. So you adapt. Now, one of the problems that we have is we make do. But when we make do, we innovate. They say when challenges comes opportunity. But what we don't do is we don't publish these things. So the thing that we're trying to do is to encourage them, as a younger people, is when these innovations come up, let them write them down, so that it does not have to come from your state in Columbus, Ohio. Why the procedure we're doing it here is, since you have that time, you're able to write it. So as well as doing the service commitment, they also have to get in this to be able to write. So challenges for them, they have to have the aptitude. They have to have the stamina. They have to have the hand-eye coordination. And it's 6 years. And at the end of it, with this program, we give them the ticket so that they can sit on the left. And usually when they go, they're going to a place where they'll be alone and or having one or other person do so. But so far, the training system in terms of getting them on board, in terms of how to select them, is quite rigorous. And because we have a very close eye on them, we tend to find out very soon those who cannot. I hope that answers your question.
So, you said there's 3 residents per year in the CSEXA program?
That is correct.
And how about in the other program?
It varies, depending on how the interviews come in. Sometimes they have about 6.
Per year?
Yeah. There was 1 year they had 8, but usually about 6. 4 or 6.
The reason why I asked that is the number of neurosurgeons in Kenya over the past. Is it just that those numbers are new numbers as far as more younger residents, or because we should be graduating around? So it has gone up.
So we have broken the barrier. Getting in is so difficult. There's so few. We actually push them quite hard. The other program, once or twice, some people have not managed to complete or have fallen by the wayside. So that there's some fallout, but that can't explain all of it. But yes, we are in the 30s now. We are.
Great. Any other questions from the audience?
I'm Dr. Senyonjo from Uganda. I know Dr. Oluoch-Olunya, we've talked a lot on phone. I know you didn't know me by face, but I know quite a number of times I've talked to you on the phone, especially discussing difficult patients. So I'm a neurosurgeon from Uganda, and it's a privilege to be in Kenya. This is home. I know Dr. Oluoch-Olunya, you were in Makere for a while, so we count you as one of our own, and we are proud of the good work that you're doing. So, that said, I know fellowship training is something that is new. Acceptability, especially by the regulator, has been
Repeating what the question is before you answer it, please.
The question really is about how the COSEXA the fellowship training program has to become accepted as a way of training surgeons. We were lucky in Kenya in the sense that some of the drivers were quite rabid, that we really knew of it. The chairman or the president of the College of Surgeons East, Central and Southern Africa at the time that we were doing it was a neurosurgeon, Professor Gershom Sunday. Some of the routes that we stepped on to get to where we were, he had done the same. So he understood what we stood for. He had interviewed both Mahmoud Qureshi and myself, and as a senior person, when he had taken over in terms of getting his M.Med and spending time in Glasgow and also spending time in Belfast, he understood the problem. So when these sites were being inspected, both in Nairobi, Khan, going to Addis Ababa, going to Mulago, it was him who was heading it. So that was part of the battle. And if you have a champion and someone who understands the process, it makes done. Done is if you are or it's in the place where you are, they will not examine. You are actually excused from it. So I'm quite happy and quite proud to be part of that team and to see that the people who have gone through the same system have as their position. Our students actually rotate. I told Andrew Yamcha, who was in Bristol. He was in Bristol for 3 years. He was there within a year or two, within a month or two, they saw what he could do. So that's what he did. That's why when he came back, he was top student. So from our standpoint then, that was what made it easier for us. So what you need to do if you have a problem with Uganda for that is get like-minded people who will also use the word advisedly rabid to be able to push people.
Thank you. May I finish it off? Sure. Okay. Thank you so much. I know that we had a bit of it, but I think it's over in the country. Of course, they did. The last time it was in Rwanda, they were quite impressed. Our medical and dental practitioners team were in Kigali and were impressed about the standardization of exams, how things were running. They were used, of course, to the university type of exams, so this was something new. But after that, it was just like this, everything fell in place. So I'm also a fellow of COSEXA. Though I understand there's a colleague from Germany. I was in Bluebird for 4 years. So I will also chat with my colleague who comes from there. I also had to speak a bit of German, so I believe that you've also been there. I'll also take this opportunity to invite the members to Kampala. I know COSEXA will be in Kampala in December. So we hope that our Kenyan colleagues will also come in. I know abstracts, we are calling for abstracts and attendance and all that. So we shall be through the organizers of this or through you, sir, get the websites to you for those who want to attend COSEXA in Kampala. Please, you're very welcome, and we shall be glad to learn from us, to learn from you, and then we see how we can push neurosurgery forward in this region. Thank you very much.
Thank you.
Real quick for Dr. Okoth.
what is your vision? Being that as the CEO of the hospital, what would you see your vision for neurosurgery and the neurosciences at Kisumu? What do you anticipate as some of the challenges that are going to be faced?
As noted that we anticipate also start training in 2020 for SEPSA. But we also want to set up a center of excellence in the shortest time possible. And I'm of the opinion, one of the people of the opinion that my leadership should not last 5 years, and we give in to new people with new ideas. So I respect my vision within 5 years we should have glories to them because we have a lot of processes to improve through research. We have to orientate our universities and our partners to ensure that these things are achieved within the shortest time. It means that we have to resource mobilize through collaboration, through institutional development, develop a proper network, and realize all this. 2 years is it is a very short time, but I think so many things have happened. Through probably certain things happen like a conspiracy, and we have a Kisumu neuroscience, and so we are having a critical mass of people who have the same interest. So I think education has was that.
Thank you. Dr. Copeland, you worked in Kenya before and left and came back. What drove you to come back?
Hospital in Bomet. The poverty and sickness, the degree of which I had not encountered before. And upon returning to the United States, was looking for jobs and whatnot. And it was hard to shake the reality of what I'd seen in Kenya. And I couldn't help but think as I was contemplating these jobs in the U.S. that at least it occurred to me that, you know, if I turned down such and such a job, I knew that I'd be quickly filled with the next guy in line, but not many were ready to go to Kenya. And so that's ultimately why I decided to go, to come back. Tenwick did not have neurosurgical care, but they had a huge need for it and were looking for neurosurgical coverage, and so that opportunity was exciting for me.
Great. Question, Dr. Gallagher?
So for Dr. Copeland.
Can we get him a mic, please? And then just if you can introduce yourself and before the question.
Hi, Rob Gallagher from New York. For Dr. Copeland, to sort of follow up on that introduction. There are 5 of us here visiting with varying all readily available. We're going home next week. You are home. So what are the challenges of building this program that you're tasked with from the ground up? And maybe you can tell us some of the things that you've done there that might be useful as they try to build neurosurgery here.
Lots of challenges. Certainly one of them was, just as you alluded to, showing up and things were much different than I was used to. So equipment was an initial issue for the first 6 months at Tenwick. I didn't have any electrical drills, so it was Hudson bracing Giggly saw, which many of you are used to, but I certainly didn't use that at all in my training. The operating microscope was an old dental scope that would attach to the bed. It was a fixed focal length. There was no observer scope, so as soon as I brought that in, everybody in the room would fall asleep because they couldn't see what I was doing. Perioperative care is a big issue. So at least in my center, we're in a pretty rural area. And so our perioperative care suffers. So you may do a fine operation and the patient dies in the post-operative period and you don't know why. That's frustrating. Finances, so both from the hospital standpoint but also the patients. Again, at least where we are, many patients can't afford the care in Eldoret or Nairobi, and I can't get to them quick enough, and so many patients suffer or die because of that. That sounds dramatic, but it's the reality. And then the hospital itself doesn't have the financial means to support at least the development and all it requires of a neurosurgical program. So a lot of the development of the work at Tenwick has come through donations. But I would say that we've got electric drills now and a nice operating microscope and hangers and clips and spine implants and I mean really anything you need other than we're not doing functional or any of that stuff. But no, it's been a challenge and continues to be, but it's certainly doable.
And we'll take 2 more questions, and then that will be it. There's a question over here, then we'll take one over here, and then we'll wrap up this session.
Good evening, everyone. My name is Dr. Samuel Njoroge, first year resident, University of Nairobi. My question goes to Dr. Oluoch-Olunya. So is it possible to have someone do MMed program and find a way of doing cross-sector? If yes, how would you advise someone to go about it?
Thank you, Samuel. COSEXA MMed. MMed program is a training program. At the end of the MMed program, you have to do 2 years before you get a specialist recognition. The COSEXA program is an exit exam. The moment you get the examination, you are recognized as a specialist. Can you get the MMed program, from the MMed program you get the COSEXA exam? The answer is yes. The 2 things that you have to do is very simple. You register, so you have a training number. Once you've registered, if you've done your MMed, you've got the equivalent of doing the MCS. So what you basically need to do is to get your logbook and make sure you've done the commensurate operations. It would be useful to get a stint where people who are COSEXA trained are, and we are very welcoming. So once you're registered, then you get you prepared for the examination because it's an exit exam. Part of it is how to not only do whatever it is you're going to do, but to think about it. So it's a very practical system, and once that is done, as I told you earlier, we are trying to get the COSEXA exam as part of the network whereby we give benchmark in the continent. So it will be an equivalent as a continental examination for benchmark. So yes, you can do both. So register when you are ready and appear for the exam. So you can have MMed and COSEXA as well.
Real quick, just to add on to that, it seems like the neurosurgery community in Kenya is really small, based on kind of what we discussed, to create a more streamlined neurosurgical training. From what I understand, it seems like the COSEXA seems more like a regional thing. Am I correct?
That is correct.
Okay. Why not streamline the program so everybody gets the same training? Would that be an advantage or not? It seems to me like if everybody gets the same training, everything would be more, there would be no discrepancies across the board. Everybody would take the same kind of exam. Is that something that has been considered?
To answer your last question, has it been considered? Yes. The inception of the training program, it was a working party in 2004. We started off together. But in view of backgrounds of how to approach training, one was taken to be a med program in the University of Nairobi, and the other one, as it's supposed to be, was a collegiate system. To come back to your question then, we have tried to harmonize the two. But in terms of the direction, we may be going in a certain direction, yes, in terms of the training, but there are 1 or 2 things, the tracks are different. And as it stands, to be able to amalgamate or to harmonize those, there was a time I was wearing both hats. I tried to do the same, it couldn't work, and we've accepted it cannot at this point in time.
But that being the case, it's not a problem because the case mix is the same. And I'll tell you, the two tracks of training systems have come together. And for the Continental Association of Neurological Societies meeting in August next year, we are as one. So, yes, it's logical for resources to be distributed in that particular way. But at the moment, the MA program is based at the University of Nairobi at the Kenyatta National Hospital with some rotations at Kigabe, and there is some collaboration with the Eldoret. And that's with the thesis, and that's how the training is being done. The collegiate system is more widespread. But in terms of the rotation process, once that is done, in terms of the assessment, it will be the same.
Thank you. Our final question.
Thank you. I'm called Alois again. I think I could be one of the few people who are at sea here. I am the head of communication unit at the county government, and it's really been a pleasure to have worked with this team from Sunday when you arrived to today. It's really been an eye-opening. I also want to take this opportunity to thank the initiative, the Kisumu Neuroscience Initiative, for organizing this symposium and for bringing the camp to Kisumu, which has really been godsend to our people. One or two questions. My governor, Professor Peter Nyang'o, has been talking consistently about making Kisumu a center of medical excellence and having this region, having Kisumu as a hub of medical tourism. And I think this is one way of achieving that vision. And I think it's moving pretty fast. Now, the question then is, this I think goes to, I don't know whether to call you Mr. Am I allowed to call you Mr.? Or it must be learned friends who call you Mr.? And I'm also surprised that people can walk from doctors to Misters. So, Mr. Oluoch-Olunya, what is the long-term vision? And this I think goes to the own of the Kisumu initiative, Neuroscience initiative. What's the long-term vision of increasing access to neurosurgery and increasing awareness of the existing neurosurgical disease burden that is in this area? I read somewhere, as we were doing some of these write-ups, that neurosurgical conditions account for about 33% of the cases that are seen at UTRH. So what is our vision in terms of increasing access and creating awareness? Two, I'm told you are now shy of 30 surgeries since you started the other day. And some of these people have been released to go home. What is your long-term plans with issues like post-surgical assistive devices? They're home. How are they being managed and how are they being worked? And three, I hear so much about the doctors, the neurosurgeons and stuff. And I'm not hearing anything about the technical support team that work in that environment. What about the scrub techs in neurosurgery? What about the nurses in neurosurgery? What is our long-term plan even as we build the neuroscience and neurosurgery in Kisumu? Long-term plans. Thank you.
Thank you very much, Mr. Gale. For the point of view of, you called me Mr. It's not a problem. If you look at my business card, it's actually called Mr. And people wonder what's wrong with me. And London friends are for liars. I'm not a lawyer. Sorry, I'm not a lawyer. So don't call me a London friend. I'll take the last question first, in terms of technical support. The way forward, there's a slide that we've done to have this discussion before with the CEO and the neuroscience team in terms of how to support the services that we do. You're quite right. You can have, as Will Copeland said earlier on, that you can do a particularly technically complex operation, but then the post-op care or the follow-up care is an issue. In terms of the training, one of the reasons why we had 5 attendings come, the other people who are with them, and I'm not going to say all their names because I can't remember, but they are there to make these surgeons look good. And I'm not kidding. The fact that Dr. Patel can look and put his hand out, and the instructor, who taught him, by the way, what to do, she gives him the exact instrument at the right time. It's because it's a team. It just so happens that the neurosurgeon is the head of it. That's all. So, in terms of the training, the amount of skill transference that has gone on, not only from the neurosurgical side, the nurses who are going to come through, the scrub techs who are coming through, when they're rounding, the surgeons will go around. But the nurses will also be checking about the notes. Have these things been filled in? What are the post-op orders? Have they been sorted out? It is very difficult to run operations if you don't have an anesthesiologist. We say, those of you who listen, who remember the late Isabella Moman, now Monday go to Kiev. The anesthetist is responsible for putting the patient to sleep and waking them up. And if you do not have an anesthetist who knows what they do, they're in trouble. Significant part of it. In terms of intensive care, the skill transference is built in. As far as the rehab side, I think there's a slide for that, rehabilitation is part and parcel of what this training should be done. When you have let them go out of the hospital, in a county hospital or wherever it is that they're going to, the kind of steps in terms of what they do, they're given some education, but they will be coming back. Cosmos is there in charge of the outpatient. He makes sure that they come back in time for them to follow up. So that technical support is built in. We're just focusing on the neurosurgeon because in terms of the resource, that's the most expensive. And there's a win-win factor, because if you can support the neurological surgeon, the other things that support the neurological surgeon will come along. Now, in terms of the second question, the surgeries that we've done, the long-term thing is, it's not tourism neurosurgery. When our colleagues have come across, they're not leaving a vacuum, in a sense that they have upped the game in terms of numbers and support and technical abilities, what they've done. When they have gone, there's a team here. Miguel is in.
When he comes back on the 21st, when he comes back, he'll be able to do so. I am here intermittently. Leo Gutha is also on the ground. And do you know the residents in general surgery have learned so much. So in terms of the trauma that comes through, the post-op care, what to look for, the rounding is quite serious because they can come up with a scan, but no, we have to tell them how to think. So in terms of the long-term and so on, that is part of the continuum. And it's our prayer that each time there's a visit, the care will go up. Each time there's a visit, care will go up. So by the time 2020 comes through, when we are putting in this as a place for training, we'll be there. The first thing you'd asked about, in terms of what Professor Nyamnyo is concerned about, this place of excellence. He is passionate about it. I've had the privilege of seeing him when I have to floss. We were from the same school. He's an old boy. I was nowhere near when he was there, but I was in the same school, so I can feel okay. Professor Nyamnyo is very serious about health in this county. The passion that he has is incredible. He was, in another life, the Minister for Medical Services. So he knows the game. He knows it from the central government. So in terms of how to get things across, he knows the steps that should be done. So in terms of access then, when you have this universal healthcare, this is one of the pilots, because he had the steps, the vision in terms of what to do. In terms of awareness, I am glad you spoke, because we were doing this job for a whole year last year. And I'm putting it back to you because there are times we had interviews and it never came out. If somebody threw a stone in Kondele, it is out of the press. But when complex neurological operations are done, it is not said. I am glad you are working with us, because people have to know. The second time when people are coming all the way from Embu, Meru for complex spine operations, Victor Ward did those. Who had? Nobody did. So in terms of access, people have to know about it. But if we work in collaboration, it'll help. Awareness of the disease burden. Dr. Okoth, the CEO, strategy, research, figures. If we don't have the figures and say this is the disease burden, do what we're doing, it will come out. But the fact that he's at the helm we are able to correlate all this stuff and get people to know. So there are figures, we know that this is a disease burden, so many traumatic brain injuries, so on and so forth, and all this will come. So it is work in progress. We are lucky because we've got champions in each and every of those departments. So I can assure you, sorry Vic, I have to say this. Kisumu is the brain basket of the country. Fish. Eat more fish. Fish makes brains. Brains makes money, and money buys more. But where are we? We are not here. We're in the US. We're in Nairobi. We're in Mombasa. These are sons of the soil. And if we go across Kisii, we're also in Nyeri. We're in Australia. But we're not here. But we're changing that. We are coming back here, and we're going to pull it here. So this center of excellence, it has started. In Columbus, Ohio, is doing all those things, but or in Germany, it's being done. Yeah? Why not? And it's here. So all your questions, the dream is there, and what the Banasio said earlier on, it's providence. All the cogs in the wheel are in there, and all these champions are working towards the help of people in Kisumu. Now, as a hub, Kisumu International Airport, it takes you 15 minutes to come from. Once you got your bag, you get to Jaramogi, 15 minutes. Hemu tried in Nairobi. 15 minutes you're just at the place where you are paying for the ticket to come out. You have not come out yet. So guys can arrive. If you come by bus, how long will it take you from the bus station to get to Jaramogi? You gotta walk. It'll get you how long? 25. Perfect. Look at the roads. Look at the bypass. Flangover. You call it flyover? Flangover. They are there. So Kisumu is a hub. We are there.
Thank you. So, and also just to clarify too, I know we were talking about the numbers as far as looking at, and I saw the view and decide if they needed surgery. We're in the hundreds at this point. So I think even though we've done quite a significant amount of surgery, but those are the people who evaluate them and decipher which ones need surgery. With that said, let's grab some dinner right outside and start going over some cases. Thank you.